We will continue our conversation about externalizing and internalizing problems by looking at internalizing problems. As a reminder, internalizing problems are behaviors or, typically speaking, mental states that impact an individual's internal world. Internalizing problems are often associated with being over-controlled or inhibited, anxious, and self-punishing. Some variables that tend to increase being over-controlled are a very tightly controlled family environment, having other associated internalizing disorders or traits like neuroticism or general anxiety, being female, and experiencing higher rates of distress. So we want to start by looking specifically at depression. Depression being the most common internalizing problem that adolescents and emerging adults experience. Now, many adolescents and emerging adults, about 35%, will experience something called a depressed mood, an enduring period of sadness. As I mentioned, this is the most common internalizing problem that adolescents have. And in fact, adolescents experience this depressed mood at a higher rate than adults do. This might not be surprising if you think back to our conversation of adolescence as being a time of emotional high highs and low lows. The most commonly reported sources of depressed mood are conflict, either with family or friends, romantic relationship disappointment or rejection, and poor school performance. However, I want you to note that depressed mood is not the same thing as major depressive disorder. Okay? Major depressive disorder is when an individual experiences 5 or more of the symptoms listed on this slide for a period of 2 weeks or longer. Some symptoms that are commonly experienced are depressed mood. That has to actually be one of the 5 symptoms. Diminished interest or lack of pleasure in things that used to make you happy. Sudden weight loss or weight gain. Sleeping too much or not sleeping at all. Insomnia, not sleeping at all, or hypersomnia, sleeping too much. General psychomotor agitation or lower than average motor abilities. Fatigue and loss of energy, feelings of worthlessness or intense guilt, diminished ability to think or concentrate or indecisiveness, and then of course recurring thoughts of death. Unfortunately, we do know that adolescents can experience major depressive disorder. And the causes here are typically genetic. Major depressive disorder does have a genetic component, but having unavailable parents or being raised in a family that has a high degree of conflict can also contribute to MDD in adolescents, as does experiencing or growing up in a family with many economic difficulties, experiencing the divorce of your parents, or generally having poor relationships with your peers also puts you at an increased risk of major depressive disorder. And then I also want to mention that MDD is diagnosed more in females than males. This might partially be because women are more likely to develop MDD, but it also is likely due to major depressive disorder being underdiagnosed in males. Males are less likely to seek help when they experience psychological difficulties. When it comes to treating depression, we typically like to see therapy as the first intervention. A lot of research suggests that cognitive behavioral therapy specifically is an effective treatment for major depressive disorder. CBT focuses on changing negative cognitions, reframing how we think about the world, and then encouraging an individual to practice new healthy behaviors. Oftentimes, when these two elements work together, we can break the cycle of depression and prevent it from happening again as long as an individual sticks with these CBT practices. We do, of course, treat major depressive disorder with antidepressants sometimes, but you have to be particularly careful about antidepressants with teenagers. Some antidepressants have been shown to potentially increase suicidal thoughts or suicidal behaviors in adolescents. So it should be closely monitored by the teenager, a parent, and a doctor. And we also know that medication works best when it's being combined with therapy. So having a therapist monitor the use of the antidepressant while also teaching these other skills is the most beneficial treatment for many people. Unfortunately, we do need to spend a minute talking about adolescent and emerging adult suicide. This is actually one of the most at-risk periods of development when it comes to suicide. And we know that suicide is actually oftentimes more likely to happen just as it seems that someone is breaking out of the cycle of major depressive disorder. Their symptoms are starting to get better. But what tends to happen here is that lethargy, that lack of energy that we can often experience during a depressive episode starts to go away, and individuals have the energy to pursue suicide. So just because someone seems like they're getting better does not mean it's time to stop monitoring them and checking in on them. And it definitely doesn't mean it's time to stop taking your medicine or stopping your therapy. Oops, give me just a second. I hit a button. We know that about 17% of 9th to 12th graders report seriously considering suicide at some point. That is a very high percent. And about 3% have attempted suicide, at least to the extent that medical attention was required. This number is likely much higher, but those attempts did not require hospitalization or even a visit to a doctor. Suicide is actually the third most common cause of death for adolescents. And that rate is even twice as high for emerging adults. So you can think of those emerging adult years as being kind of a transitional time that can often be accompanied by increased feelings of depression and its negative outcomes. Some risk factors when it comes to suicide, either suicidal ideation or thoughts about suicide, and actually attempting suicide. Whiter Caucasian individuals are more likely to attempt or consider suicide, as are females. However, males are actually more likely to succeed when it comes to attempted suicide because of the methods that they tend to use. Having disruptions in the family environment does contribute to suicide, as does substance abuse and problems with peer relationships. And then one of the bigger risk factors that we see is access to guns in an individual's household, in a friend's household, or in a related environment. So I actually want to pause on this slide for a second. Please hit the pause button on the lecture and take some time to read through the warning signs. I want everyone to be able to recognize when an individual might be at elevated risk of either suicidal ideation or actually attempting suicide. I would also like to remind everyone that there are really great resources for an individual who is contemplating suicide or an individual who has a friend or loved one who they're concerned might be thinking about committing suicide. So again, take a second, pause the video, read over this list, and when you're ready, you can proceed with the video. Before we move on, I want to remind everyone that there are resources out there, and one of the best resources that you, again, can use for yourself or a loved one is the National Suicide Prevention Lifeline. That phone number is 800-273-8255. The website is available 24/7, and they also have people on call or that you can chat with online if you are concerned about yourself or someone else. Never, ever hesitate to seek help. The last internalizing problem that I want to talk about are eating disorders, which are also very prevalent among teenagers and emerging adults. About 20% of teenage girls and 10% of teenage boys engage in what we call eating disorder behaviors. Just like with a depressed mood, eating disorder behaviors does not mean that someone actually meets the criteria for a disorder. But it does mean that they are showing some potentially harmful behaviors, such as extended fasting, use of diet products or pills or laxatives, and purging. These are pretty common behaviors among teenagers and can have very permanent outcomes. We know that eating disorders spike at the onset of puberty, and are, like I mentioned, a bigger problem for girls. About 90% of reported eating disorders are in females. Of course, the two most common are anorexia nervosa and bulimia. Anorexia being intentional self-starvation, accompanied by 15% loss in body weight. I would like to mention here that an individual does not have to look emaciated or skinny in order to have anorexia. You can have an individual who is obese but quickly loses 15% of their body weight and still meets the criteria for anorexia if they're intentionally starving themselves. Anorexia is also accompanied by the loss of menstruation, which can long-term have permanent impact on a woman's reproductive health. About 1 in 200 American teens experience anorexia. The second most common is bulimia. About 3% of American teens will experience this. Bulimia is periods of binge eating or taking in an excessive amount of calories at once, followed by purging or intentional vomiting. I also want to mention that bulimia and anorexia don't necessarily happen individually of one another. They can co-occur. So you can have someone who intentionally starves themselves for periods of time and then binges and purges afterwards. When it comes to eating disorders, we know that being white or Caucasian is a risk factor. We tend to see higher rates of idealization of the thin body standard among white women. Being of higher SES or higher socioeconomic status also increases the risk of eating disorders. As I mentioned, being a teenager or an early adult, specifically when you're experiencing gender intensification, which we've talked about in the past, can increase your risk, as does increased exposure to media and other internalizing problems. I would like to end this lecture by talking about resilience. Resilience is a trait that individuals can have where they persist through problems, good outcomes in the face of serious threat. Being resilient means working your way through life's trials and tribulations and coming out on the other side. We know that resilience tends to be associated with higher intelligence, with having at least one caring adult in your life. That adult does not have to be a parent. It can be a friend, a teacher, a religious leader, somebody at a community center, but having at least one caring adult in your life increases resilience. Having a healthy school and home environment help with resilience. And we also know that having a religious belief system or being involved in religious practice can increase or be associated with resilience as well. So the good news here is that when it comes to resilience, there are things we can do to help increase our persistence through strife. We know that emerging adulthood is particularly an important time for resilience. It tends to be thought of as the key developmental period for becoming resilient because this is when we're out on our own. We have the opportunity to take that independence and maybe leave a bad home or school situation. We now have the ability to start making our own decisions about our life on a much bigger level, a much broader level. We often start to experience new relationships, and we have the opportunity to commit to good lifelong practices and paths during this time as well. One trait that's associated with resilience during emergent adulthood is something called planful competence. Setting realistic goals, becoming dependable, and increasing your self-control are all traits that accompany planful competence, which increases an individual's ability to maintain resilience through many of these internalizing and externalizing problems.